Hello everyone, I am Rashmi Mabiyan and today we have been joined by Mr. D. Randeep, Commissioner, Health and Family Welfare Services, Karnataka, to elucidate on the vision of improving the healthcare scenario and how their plan on leveraging digital technologies for better outcomes. A very warm welcome, sir. To firstly begin by understanding how has been the scaling up of Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana in the state of Karnataka in year 2022.
Yeah, thank you for having me here and happy to represent the state as the health commissioner. As you are aware, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, it is known as Arogya Karnataka in the state of Karnataka. And we had started off a few months earlier to the national scheme itself in 2018 as a state scheme. Of course, the Government of India then launched it on a big scale towards the end of that year. And now for the past 3.5 years, 4 years, this scheme has been running in the state. Now a huge scale up has happened of the scheme itself. If one looks at it, it is the largest health assurance scheme probably in the world itself. And in the state of Karnataka, we have a good 5.09 crore beneficiaries under this scheme. And every year we are looking at what we call as the number of pre-authorizations, which is basically the number of patients who are registering in our system for the various treatments that are available under the scheme. We are close to 42 lakh such pre-authorizations, namely beneficiaries have availed this scheme. The cumulative financial outgo in terms of what the state has paid in terms of this treatment is close to 5,200 crores is what has gone in. Of course, there is a Government of India component in this as well as a state component. The state on its part has expanded the scheme even to include the APL sections of the population. We give about 1/3 of the scheme benefits. Suppose the annual scheme benefit is about 5 lakhs for a family in a BPL family. Then for the APL, it is about 1.5 lakhs. So scheme is universal with different financial caps. And in terms of how we are trying to broad base this, we are trying to bring in more hospitals in the ambit of this scheme because the success of the scheme lies in more number of hospitals being accessible. Probably after Tamil Nadu, Karnataka has the highest number of government hospitals under this scheme. And in the private hospitals also, more than 500 odd private hospitals are already in the system. We have about single speciality also another 200 hospitals. We are trying to improve the package rates. So as per the advice of the Government of India, we are in the process of adopting what is called as the Health Benefit Package 2022, which brings in a lot of competitive rates for the private hospitals to now engage with this scheme. So that this is in the active consideration of the government. Once this happens, you will notice a lot more private hospitals will also come into the scheme. So scheme, as I said, is scaled up. We are having a lot of pre-authorizations every year. This year itself, we hope to touch about 20 lakh pre-authorizations in just 1 year. We started off with something like 3 or 4 lakhs per year, but there is a 4-fold increase now in terms of the availment of these services.
And how has been the response of the private hospitals towards the adoption of this scheme? Did you face challenges?
I would say it is a bit of a mixed bag here because some of the bigger hospitals have expressed reservations on the low package rates. So they have always been telling us that once the package rates are increased or aligned with Government of India, then they are in a position to come in. But our perspective has always been that this is a national scheme and there should not be a choice for the private hospitals to choose. And we should make this obligatory, and as a social responsibility, they need to come up. And we are not asking for all the beds in the private hospitals, close to 20-25% of the beds, as and when required for a government referred patient under the scheme should be available. So we are in touch with the private hospitals network. But I'm sure that if we take this one step forward of introducing the Health Benefit Package 2022, then we would find a lot more private hospitals coming in.
Okay. So going on to the next question, I'm going to focus a little on the operationalization of Namma clinics. Could you tell us what are the major challenges that you see in the functioning of these clinics, and what is the plan of action for them to actually proceed forward?
In fact, Nama clinics has been conceptualized by Government of India, basically on the concept of a neighborhood clinic, which is available close by for the urban population to access, reach out to for these facilities. As you know that in the rural part of Karnataka, we have sub-centers. Even below the public health centers, we have sub-centers. Now, the concept of sub-centers in city is largely rare, simply because of the place constraints, and normally we find the bigger hospitals. So one forgets the concept of preventive and promotive healthcare. So in that regard, Nama clinics is kind of reawakening the thought process that we need to shift towards preventive and promotive healthcare. Primarily, when you look at aspects like nutrition, when we look at our lifestyle management, if you look at the non-communicable disease burden that is there in the state today and across India. So what kind of preventive interventions that can take place, and the overall wellness of an individual. So Nama Clinic is largely revolving around this, that it creates that awareness. There is that access for someone who is not very well off, who cannot afford private healthcare in an urban setting. The Nama clinics are available for them to access quality and affordable healthcare at their doorstep. There are about 438 Nama clinics which are sanctioned for the state as a whole. Okay. And the Honorable Chief Minister of Karnataka and the Honorable Health Minister and Medical Education Minister, they would be jointly launching about 100 of these. Once that is launched, then the others would also follow.
So, sir, you talked about preventive and promotive healthcare. My next question will be touching on these. What is the state's long-term initiatives? How is it aimed at reducing the burden of communicable and non-communicable diseases?
Yes, so communicable diseases, I would say, is largely seasonal. Some of them are endemic. So we have our own strategies for handling them. Of course, you have seen how the state has done handling COVID, our burden of respiratory illnesses. We have the advantage of a lot of Government of India programs in line to handle these diseases. We also have the IHIP portal, which is a national reporting portal, where any kind of such infectious diseases, communicable diseases are reported regularly. So we have a good, robust reporting network, and our interventions are largely revolving around them. Surveillance also revolves around them. But the larger challenge, I would say, for the state is the rising burden of NCD. And this is something which the country has also recognized. And it is very tough to reverse conditions like hypertension, diabetes, other cardiovascular illnesses once they set in. So the whole concept has to be around targeting an awareness campaign, trying to bring in better nutritional habits, trying to improve the lifestyle of the urban people, just to ensure that they do not slip into those categories of diabetics, hypertension, so on and so forth. We have a lot of, during our surveys, we did find that a lot of them are in the pre-diabetic stage, even as early as in their early 30s. Now, this is the urban population that the Honorable Health Minister has also been, Dr. Sudhakar has also been repeatedly urging us to do, which is having a statewide campaign to ensure that all those above 30 are screened for NCD. So once we are screened for NCD, we really know that what is our burden that we are actually working on? How many are there in the pre-NCD stage? And how many will slip into them? What would be the kind of treatment burden that would come on? What would be the out-of-pocket expenditure? How do we bring them into the Ayushman Bharat scheme so that really they are not driven into what is called as the catastrophic expenditure, which drives most of them back into poverty. So these are the larger goals. And I think NCD, there is a very close focus. The state has also been working on what we call as the declaration of the Arogya city, which is for Bangalore, and the Arogya state concept. And what is it that we can do through these interventions like the Nama Clinic has been the larger objective of the government.
Could you tell us about the COVID learnings from the pandemic and that have been adopted by the facilities for better improvement and better care delivery? And what are the best practices that have been implemented after that?
Look, COVID was a game changer for all of us, and for the department also, it was no less. Um, uh, the kind of interventions that one had to intervene from the state as well as the city, because if you look at the COVID load that hit the city of Bangalore, it was literally about I think we were hit with about 2/3 of most of the COVID cases came from the city of Bangalore. So an urban population which was hit to such a large extent, I think the department had to come as a whole and had to have a lot of interdepartment coordination. Most of our reviews actually happened online. We were forced to do that because even amongst the workforce, even amongst the officers, we did find a lot of them falling sick during that period. And one had to always be on the move in terms of having our interventions on the ground, having the reviews. So that did teach us a lot in terms of how we can work much more effectively remotely, decentralized manner, with some kind of a centralized approach and directions being given. We used our reporting formats to the hilt. We had close to about 20 different applications which were launched in the state of Karnataka. All of them were used digitally in Karnataka, having the advantage of more smartphone users, more electronic gadgets, the availability of good internet speeds. This kind of enabled that more of our interventions in COVID, our responses were that much more faster, much more efficient, because we use these digital tools. Just to cite that apart from vaccination, which the COVID portal, which Government of India provided to us, we ourselves had about 5 to 6 in-house built applications developed by e-governance, developed by our own officials in a very short time. So that kind of helped, and many of these applications have now modified into the regular reporting systems that we use for disease surveillance, communicable disease burden estimations. All of this has helped us improve our systems to a large extent.
So what are the measures that are being taken to re-establish the importance of general physicians and the primary healthcare centers?
The very concept of the Nama clinics is having a physician there on board in the Nama clinics itself. If you look at the rural sub-centers, we have gone in for a large recruitment of what are the community health officers. Okay. So slowly we are, of course, while the tertiary care, our district hospitals, taluk hospitals have the specialists on board, but the general physician is of absolute importance, because the preventive and the promotive aspects and the first level kind of intervention, the early diagnosis, all are going to happen at that particular stage. So the state is investing heavily in both the rural setup, where we have the rural doctors. If you find, we have about 2,500 odd public health centers, primary health centers, and short of about 100, all of them are filled, which means that we have a good number of physicians who are working, the general duty medical doctors. And now with the Nama clinics coming into play, we are going to have the medical officers even at the urban settings in these Nama clinics.
So there were also reports of Karnataka State Medical Supply Corporation Limited procurement being delayed due to the COVID pandemic. And what has been the corrective action taken to avoid such delays that could result in shortage of essential medicines at healthcare facilities?
So Karnataka follows a single source of procurement through the Medical Supplies Corporation. We do not do disaggregated kind of procurements. We do it centrally. We have a very robust system of the tendering system, which happens through the corporation. Now, what hit us was the COVID pandemic, as you are aware. That delayed the general drug procurement to a large extent, because the focus entirely shifted into procuring those 8 to 9 mandatory drugs which Government of India had mandated, associated drugs for respiratory illnesses. There were 2 or 3 drugs which were extremely essential, which needed to be procured. So the regular procurement programmatic drugs and the regular drugs was, I would say, delayed. I would upfront admit that. This year especially, that is the start of January to now, which is almost about 10 to 11 months, we have tried to push for procurements which could not happen for the last 1.5 years. Be it the programmatic drugs, which is under the Government of India scheme, as well as the essential list of 440 odd drugs and consumables which we had to procure. Now, close to the end of this calendar year, we still are short of about 32 to 35 essential drugs. But we have completed 95% of the tendering process, which had to be completed for the year. The 35 to 36 odd drugs which still need to be procured, we have already written to the hospitals and the establishments that they need to do what is known as a local procurement, because for various reasons, this could not be centrally finalized. Lack of competition, the rates being very high. So this list has been shared with the establishments. And the good thing is that a lot of money now is going directly to the establishments through the National Free Drug Supply Scheme of Government of India, as well as the states. Now, we were just talking about the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana scheme. Since I have almost around 3,000 public hospitals actively participating, a lot of this package money on treatment goes to these hospitals. And many of them are now with relatively good amount of funds available with them. We have said that on priority, the Ayushman Bharat funds can be used for procurement of essential drugs and consumables. So really the health establishments today are far more comfortable because we have completed the centralized procurement. We have also told them what to procure locally. And for the next year, I mean, not to repeat the errors that were there last year, for the year, financial year 23-24, which commences from the month of April 2023 and goes up to March 2024, we are pleased to say that we have initiated the process of tender already, so that we complete the process by February, January-February, and the agencies who are selected to supply these medicines can commence their supplies from the start of the financial year itself, which is April 2023. So we are pre-planning this time, just not to miss the bus. And I'm sure that the entire gamut of drugs that need to be procured for the forthcoming year will be done much in advance this time.
Next question, I think, would be a little close to your heart because it's related to technology. How do you think the adoption of digital technologies like 5G in the coming year will propel digitization in the healthcare landscape of the state?
Look, Karnataka has always been at the forefront of digital technology. We have never said no to any kind of interventions, and health is no less behind. We urge to have faster internet speeds. We would want a lot of our field level functionaries who go out on the field to have access to good network, because there is a lot of expectations from them in terms of real-time reporting. Be it our ASHA workers, our auxiliary nurse and midwives who are in the field. Also, if you look at most of our field officials in certain programs like which involve a bit of a surveillance, be it the NVB DCP program or the IDSP program. So good network, good coverage, faster speeds always help in timely reporting. So that's something which Karnataka has been looking at with eagerness, and 5G, I'm sure, will help us. Another way it is going to help us is we have a very robust MIS system in our hospitals, which is the e-hospital system developed by NIC. We have close to 400 odd hospitals which are already on board. We are looking at ensuring that even our PHCs are going to get powered, which means over 3,000 odd establishments coming under this particular facility, HMIS. And all this requires a very robust backbone of 5G and internet speeds and data storage capacity, which our state data center is also working on. So this is something which we keenly look at, and we'll have to take it ahead. And also, as someone who looks at the Ayushman Bharat digital mission also, this is a primary goal that we try to digitize our services to the maximum extent, so that patients find comfort and even the caregivers are able to access our services digitally and remotely.
Thank you so much, sir. Another part of this question was also on how it's going to benefit the government hospitals and especially smoothening the administrative process in it.
Yeah, so if I can talk about the Ayushman Bharat digital mission, this is what exactly the mission aims at. So it is trying to look at a paperless kind of an administration in the hospital. We already have largely less paper offices in the administration. If you're aware of the e-office facility that is available through the NIC, most of our files that we see today are basically digital files. We have limited largely the paper files. Now, if you look at it as a paradigm in the hospital sector also, right from issue of an OPD slip to issue of a prescription, issue of your slips for the diagnostics, your hematological reports, if all of this can be available at a click of a button, if they could be available on a person's mobile or can be delivered over an email, I think that is where we are looking at some kind of a revolution to come through. We have taken some baby steps in terms of digitizing our internal processes of the hospital presently, but the interface with the public is something that we are working on. Just to illustrate, under the ABDM, we have brought something known as the fast track counter. So people no longer go to the hospitals and wait in a queue to take their OPD slip. They just go through a QR code mechanism. They're able to, once of course they get their ABA ID, they're able to push their data into their HMIS through the QR code. And automatically a token generates. Until the token generates and the token number is called, the patient can very comfortably sit in a chair and wait for his or her turn. So there's really no rush at the OPDs in these hospitals which we are implemented. We've seen fabulous response and a great adoption to digital intervention. So I'm sure that as long as we focus our digital interventions towards the benefit of the patient and the caregivers, the adoption rate for this will improve. And all digital interventions at the end of the day have to be supported by a very robust server system as well as the internet speeds.
Thank you so much, sir. Thank you for sharing those great insights and the plan of action on improving healthcare and the scope of digital technologies for revolutionizing the healthcare.